Hi, I'm Ralph Preston. Welcome to Stroke Buddies Tuesday Stroke Survivor Support Group meeting. Today we have Mitchell Raymond, and Mitch is going to tell us a little bit about his story as a stroke survivor who became a physical therapist, and a little bit about his practice. And there are many things about his practice. One of the things that I found interesting was proprioceptive neuromuscular facilitation. And I'll let him explain that since I'm here to learn like the rest of you. So take it away, Mitch.
All right. Well, hello. My name is Mitch Raymond. I currently practice in the home care setting, although I have practiced in skilled nursing facilities as well as in the hospital setting. So I had my stroke when I was 6 years old. It was a result of benign brain tumor extrusion. It was called an oligodendroglioma. It was wrapped around what's called the middle cerebral artery, which is an artery that's right here around the temporal lobe that supplies blood to that area. When they surgically removed it at Boston Children's Hospital, the artery was punctured, leading to a hemorrhagic stroke to the right side of my body. Left side of the brain controls right side of the body. So when I first came out of surgery, I had complete flaccid paralysis of my right side, meaning no movement whatsoever, a facial droop, double vision, as well as what's called autonomic aphasia, which is difficulty with word retrieval. So from there, I had to receive all three disciplines of speech language pathology, occupational therapy, physical therapy. I was there at Boston Children's Hospital for rehab for about a month, and then I got transitioned to Connecticut, Newington, Connecticut, where there's a children's hospital rehab center there. And eventually I transitioned home and had to have in school therapy. I also had to stay back in kindergarten because this basically ate up the year that I was in kindergarten. So anyways, I continued on with my life with therapies. I had speech therapy for about 6 years, occupational therapy for around the same time, but physical therapy is what I've done pretty much throughout my entire life. 33 years post-stroke, I'm still doing physical therapy on myself as well as on others. So let's see. Just to put it in perspective, I used to be very, very much all woes me about my situation, how it was unfair, that things were certainly harder for me than for others. Like, for example, when I was 6, I was starting to develop being right-handed. I was becoming a right-handed kid, and then I had the stroke, and then I had to switch to being left-handed. So that in that of itself was very difficult, and I had to kind of everything seemed slower, especially in terms of writing and word retrieval, but it just made schoolwork a lot more difficult. But then later on in my life, when I was, I want to say, third grade, fourth grade, I got introduced to the Vermont Special Olympics. And in the Special Olympics, what was really key about there was the fact that, yes, I had a disability, but everyone else had a disability as well. And some people who had more involved disabilities outperformed me. I always go back to this one example, my good friend Betsy Hurley, who has spina bifida, no use from the waist down, basically a spinal cord injury. It was congenital, in the womb, but she never had use of her legs. She skied in what's called a bucket ski, which is a chair that's on a framework with springs to a monoski. And then if you know what loft strand crutches are, they're crutches with a cup or a clasp around the forearm, a handlebar to hold on to. She had two of these. On the distal ends of these outriggers were these skis, and she could go down moguls, she could go down glades, she could go down anything. And me as a skier back then, I was scared to death of that sort of terrain, going down bumpy terrain, and she could do it like nothing. So that just kind of put things in perspective, like, okay, well, I have a disability, but I can't do as well as she. So, maybe life isn't that bad, and I can really strive to be like her, to be able to do those things. So later I went through being an athlete, and then I became a coach of skiing, and then I became a ski instructor at Bromley Mountain in Vermont. And I really just learned to be a professional and to how to teach. That's where I really learned how to break things down for my students and my athletes that I coached. So fast forward through high school, I chose not physical therapy for my first concentration. It was aerospace engineering, if you believe it or not, rocket science. And I did a semester of that, and then I'm like, oh well, this is not enough people skills or whatever. I'll try astrophysics. Nope, that's not right. So I took a year off, and this is where I started job shadowing physical therapists. A key point in that part of my life, though, however, when I was at BU, I neglected my right hand. And if you know what it means to neglect a stroke affected extremity, it gets worse. So I had spasticity, so the spasticity got worse. If you can see my arm, it started to come up into this position as I neglected. So the less I worked it, the more that spasticity really tried to take over. So I saw how bad that was, and basically said, I got to take a year off. I got to figure out my life. So I took a year off. I was a cowboy for a little while, went back to ski instructing, caddying, all that stuff. But I started job shadowing PTs and learning the hows and the whys behind physical therapy interventions. Because until that point, I was just a patient, like all of you. And that was really inspiring. I was like, man, I gotta get me some more of this, not only for myself, but if I could, use it to help others. So I applied to Quinnipiac University and got in. And having a spastic right upper extremity, my right arm and hand, I had to be adaptive to everything that I did. How physical therapists do a lot of hands-on. So I had to be adaptive with my hands to do the techniques that we were taught. And most of my instructors were supportive, not all of them. But I eventually got through and passed my boards the first time around. And fast forward to today, every time I see an individual status post-stroke, they are an inspiration to me. I have a lot of ways that I do things that have been further developed and further enhanced through what I do with my stroke survivors. So I'm going to get into a little bit of the core of what I do with my physical therapy patients, and then we'll open it up to questions. So at the core of what I do is I try to make my patients aware of how our brains control our muscles. So every single muscle, first of all, did you guys know that there are about 620 muscles in the human body? And our brain organizes and controls all of that plus everything else, which I find it's absolutely fascinating. So every single muscle of the human body has two impulses, two inputs from our central nervous system, which is activation, tensing up, and inhibition, which is relaxing, letting go. Okay. And it's not an all or nothing thing. There is gradation of varying tonalities of activation versus inhibition as you move through the range or every range of motion. And it's not working at one joint. There's always multiple muscles working for your movement. Take walking, for example. It's a whole chain of muscles that is working for you as you go through each of the phases of your walking. So when it comes to spasticity, however, and hypertonicity, which they can be kind of synonymous. Spasticity specifically is velocity dependent. I always do this demonstration for my patients because I have spasticity. My elbow, if I don't pay attention to my arm and just at a fast pace extend my elbow, it catches. However, that's with me not focusing. However, if I focus on inhibition, I'll do the same velocity and I can go further. Do you see? I was able to go further into the range without that spastic catch because I was focusing on the aspects of inhibition as I went through the range. So what is spasticity? What is hypertonicity? We have to know that before we can really combat it. So spasticity / hypertonicity is basically a reflex arc between the anti-gravity muscles and our spinal nerve roots without intervention from our brains. So our brains are detached from those muscles and reflexive activity is taking over. Okay. So when it comes to trying to open up my hand, for example, and if I'm not consciously engaged, it's fighting me all the way. And the harder that I work against it, the harder it produces a reflexive reverberation activity between my spine and my muscle and spine and my muscle. So if you're stretching a stroke affected extremity without consciously trying to inhibit that, you're not doing it any good because our injury was not to our extremities, wasn't to our arm, wasn't to our face, wasn't to our leg. It was to our brain. So that should be the area of focus, is trying to get your brain connected. A stretch should never, ever, ever, ever be passive. It should always be conscious because what you're trying to do is foster inhibition. And you should be fostering both activation and inhibition. And that's where PNF comes in. Proprioceptive Neuromuscular Facilitation is all about that basic concept of mastering activation and inhibition of isolated muscle groups, but then also synergistically throughout an entire range of multiple joints, trying to control your extremities in a functional way. So when I want to inhibit my hand, I go through a series of things. I breathe, for example. Breathing is crucial. Okay. If you guys don't know what the autonomic nervous system is, I'll just give you a brief rundown. There's two components of the autonomic nervous system: excitation and inhibition. Okay. Excitation is sympathetic. Relaxation is parasympathetic. Now, what does the autonomic nervous system do? It makes our heart pump. It basically controls all that stuff in our innards that is on autopilot. Okay. However, there is one aspect of the autonomic nervous system that we have conscious control over, Everyone take a deep breath. Right? You just overrode the autonomic nervous system with your conscious thought. When you go to sleep at night, do you tell yourself to breathe? No. You just breathe, right? Your autonomic nervous system is making sure that you breathe. However, we have the conscious ability to influence our breathing. And therefore, that is our doorway in to the autonomic nervous system. Has anyone ever snuck behind you guys and went, boo? And you went, and what did your body do? Your body tensed up. When you inhale suddenly or hold your breath, it fosters muscle guarding, tensing, and especially your stroke affected extremity. If it has spasticity, it will tense up. Okay. Have you ever come home at a long days of work, you're even PT, and you're really tired? You sit down on the couch and go, okay, what happens? Your body relaxes. You just tapped in to your autonomic nervous system, your parasympathetic portion of the autonomic nervous system, and helped your body to relax. So if we can harness the parasympathetic nervous system through exhalation and consciously relaxing during exhalation while we stretch, we can help the inhibition of our hypertonic muscles. Now, I know not all of you have hypertonicity / spasticity. However, all of us can benefit from this because all of us muscle guard. Did you guys know that? Every single one of you, when you stretch, when you go into a hamstring stretch or a quad stretch or tricep stretch or a bicep stretch, any sort of stretch, the first phase of that stretch is a muscle guard. The first feeling of stretch that you have is your reflexes taking over and saying, whoa, 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 don't break me, don't make me bust. Okay, so how do you bypass that? So you go into that first range, and then you keep it in that range and you relax. And then you go a little bit further. And when you relax, you exhale. You, right? You try to stretch your hamstrings. That first phase is a muscle guard. So you can just totally relax, exhale, like let the lymph go relax, and then go further into the range. You can also do what's called contract relax, where let's say you're firing the hamstrings, and then you tense that hamstring into a knee bend without moving your foot, and then relax it again and exhale, and you can go further into the range. Does that make sense to all of you? Okay. So these are ways to override that muscle guard. Again, every stretch, this is what I want you to take home. Every single stretch that you do, no matter if you have a stroke or no, the first feeling of stretch is always a muscle guard, unless it's painful. That's usually arthritis and maybe nerve impingement and stuff. If it's painful, you need to see someone. You need to see a physical therapist, occupational therapist, a physiatrist. Pain is something that needs to be addressed. Orthopedic physician. Pain is always a way for your body to tell you something isn't going right. You need a little bit more input from someone who knows the body to avoid that. It's not something you should. As a physical therapist in the beginning of my career, old school orthopedic physical therapists were all about no pain, no gain. Kind of like those old football coaches. And no pain, no gain can actually lead to injury. It's a really poor method of practice, both in the athletic side of things as well as physical therapy. So I always say, let pain be your guide. Let pain be your guide. All right. Let's see. Anything else? Oh yeah. I have to note that I have this whole philosophy of stroke rehab, post-stroke rehab, that the area of your brain affected by stroke in a lot of cases kind of reverts back to infancy. I find infants to be very inspiring to me as a stroke survivor. And I hope they're inspiring to you too, because when they come out of the womb, can they do much? No, they can't do much at all. They're basically lumps. They twitch, they move around a little bit, but can they sit up? Can they roll? Can they do? No. You have to even support their heads, right? They can't even hold their heads upright. Okay. So that's very similar to flaccid paralysis. If you come out of surgery or you had a stroke and all of a sudden you're not able to move an extremity or an entire side of your body, that side of the body has been reverted back to almost like infancy stage. And it is up to you, to, in our case, we have to rewire and remodel through neuroplasticity. In the baby's case, they need to wire from the first get-go. Okay. But what's key here is the time that it takes for this to happen. Can a baby just get up and walk right out of the womb? No. It takes them how long? Maybe 9 months, 12 months, depending on the baby, right? It takes them a long time. And how many tries and fails do they have? A ton, right? They have a ton of tries and fails. And how much do they nap? Don't babies nap a ton? It's very common for us stroke survivors we get tired very easily because our brains are working hardcore to rewire and remodel, and that takes a lot of neurologic energy. Okay. So when it comes to you're getting tired, don't be ashamed of that. Every time you sleep, your brain is mapping and remodeling and devoting that that energy and those resources to whatever you knew that day, whatever you learned, it's being integrated into long-term memory during hours of sleep. Our brains are very active during hours of sleep. That's why sleep is so crucial. My professors once told all of us PT students that we should never pull an all-nighter before a test and not get sleep. And we shouldn't make a habit of doing that because we may be able to regurgitate the information for the exam, but it won't stick. We won't have devoted that knowledge to long-term memory. Take that back to us stroke survivors. If we don't get a good night's sleep and take naps when we need to take naps, our rehab is severely hindered by lack of sleep. The new skills that we learn, the new gains that we make, do not get devoted as well to long-term memory, and it makes life a lot harder if we don't get our sleep. So let's see. We covered activation versus inhibition. We covered spasticity. I can cover a little bit of anomic aphasia if you want, but I think right now, Ralph, let's start opening this up to questions and see where the conversation takes us. Okay.
Okay. I could start with something because doing yoga, I'm aware of the power of breathing, and one of the things that takes you a while to do when you start doing yoga is to remember to do your deep breathing and to do it while you're doing the stretches and other things and kind of try and coordinate them. And so I sometimes I diaphragm breathe or deep breathe when I'm doing bridges, and after listening to what you were talking about, and so I kind of like I go up and breathe, and then I exhale and I let it back down. And I'm wondering if there's I'm concerned that there's a right way and a wrong way, and I might be doing it the wrong way.
Um, I mean, as long as you're breathing, that's key. But if you want to optimize your neuromuscular control, exhaling into the range of motion fosters neuromuscular control. better than inhaling, because basically if you're going into a resisted range and you're inhaling into that range, you're fostering muscle guarding. You're fostering that the opposing muscles resisting you. Does that make sense?
Yeah.
So if you're going into a resisted range and you want to focus and optimize that range, whatever I mean, with bridging, you're using a whole bunch of muscles. It's not just one joint that you're doing this at. You want to try to exhale so that, like, say, your abdominal muscles don't kick in and your hip flexors don't kick in as you're trying to use your hamstrings and your glutes and your erector spinae muscles to bring those hips up. Okay. Does that make sense?
Yeah, and I'll need to get down on the mat and, well, you noodle around yourself, so I'll have to get down and figure it out. But it seems like if I breathe in on the up, I'm working against it. So maybe
Yes, you are.
I should be breathing in
Going down.
on the going down and exhaling on the up.
You
So
got it.
I mean, so
And
here's
it's
the way.
counterintuitive.
No, not necessarily. And the reason I ask you to clarify this is not for somebody else doing bridges, but to make the whole concept more clear. Not that you didn't explain it well. I just thought, okay, well, it seems to me I'm doing bridges backwards. So, like you and I talked on the phone, a lot of things you have to do, you have to bring them to your personal experience. The takeaway from this is not like, you can't like write up a sheet that everybody can follow. You give us knowledge, and then we have to adapt it to the exercises that we're doing and whatever. So I'll get down on the mat and I'll try exhaling on the up and breathing in when I hold it. And then maybe I'll be working it more. I'm doing it mostly for core as opposed to recovery, because I probably have done most of the recovery that I'm going to be able to do. I believe in neuroplasticity. I've learned how to do things, to prove neuroplasticity. I've made videos of myself learning to throw a tennis ball or something that I didn't know how to do before, to demonstrate it. But I'm not likely to make a lot of improvement because I do most everything. So,
Well, can I speak something contrary to that, Ralph?
sure,
Yes,
absolutely.
you can improve beyond, like, you're thinking of back to functional status, and that's a very physical therapy way of thinking. You may be to the level of going beyond therapy, and it's okay to go into that realm. That's, if you have achieved everything that's functional, you got to think beyond functional now. You got to think maybe athletic, maybe recreational. It doesn't have to be like, you don't have to strive to be an Olympian, but let's say that rock climbing, is something you want to pursue, or just, maybe climbing over rocky terrain. Maybe you're kind of concerned about your stability, climbing in various ranges, kind of monkeying around. Or if you have grandchildren and you want to get up on those monkey bars with them and show them how it's done, it's that's the sort of dreaming that you have to think about, and not just get stuck in functional. If you have already achieved functional, you can always improve, always.
Oh no, I believe that. I guess that I do everything that I need. I do most things, fairly normally. I go up steps without holding on. I go up steps with things in my hands and not worry about the railings. That took a
Yeah,
while to like get rid of that fear
yeah,
stuff. What you're talking about now it made me think about something that you know more about, but you and I share an interest in. And you were talking about it when you were saying there's always something more you can do, the dreaming aspect, and that's play,
yeah,
involving play in your therapy. Do you want to
yeah,
talk about that for a sec?
absolutely. So I have been inspired two ways with regard to play and therapy. One is just having kids. I have a 5-year-old, I have an 8-year-old. Do they like play? Absolutely.
Yeah.
Um, and they through play they experiment and they explore and they figure stuff out through their play. Why can't we adults do that? There's no reason besides us being, oh, I know everything already and play is for kids. Like that's a cop out in my opinion. That's a complete cop out. So the other source of inspiration for play is my wife. My wife is a pediatric occupational therapist. With her clients, can she do adult therapy interventions? Absolutely no. Maybe in some modified shape or form in teaching the parents on how to do it on their kids or something like that. But kids can't think. They don't have the executive function to
Mhm.
be able to do adult style therapy. So she has to do it through play. And again, I'm thinking, why can't I, as a therapist, make it fun for my clients? And so once I teach them the basic principles, especially stroke survivors, we start to experiment. We start to explore. We start to be, I try to, with all of my stroke clients that have the cognition to do so, I try to make them my scientific assistants. Kind of like I'm a mad scientist, and I'm not maybe mad, but just a very intrigued scientist. And what happens if we do this? What happens if we do that? Let's test this out. And I obviously this is all within safety parameters. I don't do something crazy. I keep maintain safety at all times, but that mentality of let's try something new, let's try something different, see if it works, is how I've developed a lot of my newer interventions that have yet to be tested by peer-reviewed research. And through this experimentation and inspiration of stroke survivors, I've actually started to branch out with what I've learned from us as stroke survivors to other pathologies like Parkinson's disease, total knee replacement. With total knee replacements, does muscle guarding happen? Oh, heck yes. And muscle guarding is very similar to spasticity and hypertonicity. And I've found that those interventions work with those populations. So again, all within safety parameters, but I am not afraid as a therapist to explore. So back to play. Basically what I'm doing in therapy is my own version of play. This is what makes therapy fun for me, and fun for my clients, is playing around with stuff. Um, well, take gait training for example. If we just walk forward all the time, that's pretty darn boring, isn't it? What about sidestepping? What about cross stepping? What about turning around? What about dancing? Put on some music. Let's dance together. You know, do the foxtrot. The mashed potato. It may sound silly, but it makes it fun. It makes it engaging, and that is crucial to your ability to foster neuroplasticity, keeping it interesting, keeping it fun, exploring. That's what we all need to work on as stroke survivors as well as therapists in order to make it engaging. It also needs to be meaningful. And what do I mean by meaningful? Meaningful is tapping into your background, your history, your interests. It could be the way that the learning style. I know a lot of my clients who are former scientists and engineers love the nitty gritty, the nuts and bolts of in the mechanics and the breakdown and the scientific whatever. And my artists like to not learn so much about that, but just be creative and explorative. And maybe they like to have me just foster the artistic experience with them. I forgot to go through the 3 phases of post-stroke rehab. Sorry, guys. So 3 phases of post-stroke rehab. This is kind of the framework of my entire series of interventions. It's called the range of motion series, or range of motion phases of post-stroke rehab. Increase range of motion, explore range of motion, apply range of motion. We've already covered some of the increased range of motion. That's through actively going through the range, dealing with spasticity, dealing with that activation versus inhibition, stretching, conscious stretching, that sort of thing. Explore range of motion is where you can get artsy. You can be improvisational. If you have an stroke affected extremity, put yourself in a safe position, like on the bed. You can do all sorts of exploration on the bed. In sitting, in standing, you got to be careful, because if you're not sure of yourself, and you don't have good balance, if you're exploring your range of motion in standing, you throw yourself off balance. So if balance is an issue, standing is a big no-no unless you have someone guarding you. Explore range of motion we get into the very much the teacher-student mentality. If you have a non-affected side and a stroke-affected side, the non-affected side you can either have that affected side move first in an improvisational way, and then have the stroke-affected side try to do some variation of what your non-affected side did. You can do them together, so they work in synergy. Yes, work in synergy, work in concert with each other. Oftentimes when, like, for example, if I'm having trouble getting the hip adductors to work, those are your inner thigh muscles. If I have you in hook lying, I'll tell you to bring your non-affected side against my manual resistance. And by doing that, and I said, okay, then fire your affected side, that will draw your affected side it would bring your knees together. Basically, if I statically resist the hip coming inward and the knees, let me see. If I statically resist, that draws the other knee in. Does that visual prove good? Okay. So those are little tricks. So that's it. Oh my God, I'm getting a reverberation. Sorry.
Oh.
Anyways, someone must have had their mic on. So that explore range of motion can be that. It can be turning music on. I like, Enya, Yanni's soundscape music when I'm exploring my range of motion. And you just kind of, in laying down position and sitting, if you're really good and really balanced, you can do it in standing. You dance. You move improvisationally and slowly to those ranges. And slow is key, especially if you have spasticity. If you're moving high velocity with spasticity, you're just going to get a lot of spastic catches and a lot of difficulty with motion. If you move slowly, it fosters a little bit more of that exploration of neuroplasticity and that mind-brain connection. And then what is apply range of motion? Apply range of motion is basically CIMT, constraint-induced movement therapy. It's using your stroke-affected extremity functionally and in a meaningful way. So again, what do I mean by meaningful? It can be as basic as bringing a cup of juice to your mouth and drinking it, brushing your teeth, combing your hair. Those are basic things. If you used to be an artist and used to draw with your right upper extremity or left upper extremity, you can draw with your stroke affected extremity, and that's a meaningful thing for you. If you were a writer, if you used to like to write print or cursive, you can try that with your stroke affected extremity. The possibility, if you used to be a former baseball player when you were a kid, you love baseball and you want to play catch with your grandchildren or your child, work on being able to throw that ball. So these are meaningful applications, and it's forcing the use of your affected extremity. Now that's upper extremity. What about lower extremity? Walking, obviously. If you're a former skier, maybe just walking around in ski boots for the first time, before you even get onto skis. As a ski instructor, when I had kids, fresh off the boat, never skied a day in their life, the first thing I did with every single student was play boot games. We didn't even put the skis on. We just did everything we could to get the kids comfortable in the boots. And then we just put on one ski, and we did this is all on level terrain, one ski, and we did games with one ski and then two skis, and we broke it down. So that's the other thing. All approaches to new things, you gotta really learn, maybe, and you may have to have an instructor to do this, or a physical therapist or an athletic trainer, is break things down into their components, find where your weaknesses are, and then build it back up to the full picture of what you want to pursue. um, I really went off on a tangent. Sorry,
Oh,
Ralph.
no, 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 no. It was all good, and it's good stuff. I got about three questions because of it, but um, one of the things, going back for just a sec, was, do you think that one of the things that I find is that I sometimes have made gains when I was able to do things like relax into something, put music on, walk with music, some of those things that you're talking about, like play, because I somehow stopped. I use the term overthinking. I recently interviewed Brian Harris, and he called it cognitive interference. But we're talking about the same thing. And you, as a stroke survivor, know what I'm talking about. 13 years out, I am. You're more than that. You're 33 years out. I haven't, in 13 years, I haven't hardly taken any steps where I don't think about them. And occasionally I have a period where I walk across my backyard and I realize I'm in automatic mode and I'm walking perfectly. And I've tried to connect with that, try to get rid of the cognitive thinking. So I was wondering if you thought that, play and music and some of these things actually might help with getting back to automatic mode. And since you're nodding your head, I think you understand and agree that
Yeah.
there is some kind of automatic mode that is a target for us to get back to.
The reason why you and a lot of other people are conscious about their motor planning is fear of falling, fear of loss of balance. You feel that you need to stay consciously connected for fear of misstepping and falling. And that's what all of us adults have to fear that all the time, because are we higher from the ground than kids? Yeah, if we fall, we break a hip. If they fall, they get a little bump. They bounce. And if they have diapers, they have extra cushion. Okay. So in order to practice reducing that, getting rid of that, and just being able to flow and play, you gotta find a way to eliminate or minimize that fear. And one way I found, and this is how I learned to walk again, really, was pool therapy. Now, you don't have to seek out a pool therapist if you feel confident. Just seek out a pool. And if you lose your balance in the pool, what happens? Well, you get a little wet. The buoyancy factor catches you, you right yourself, and you can do all sorts of wonderful things in the pool and really explore and just throw caution to the wind pretty much, because you always have that buoyancy to catch you.
Oh yeah, I'm not a pool therapist, so I've taken 7 people to the pool. I act like a pool therapist, and and I completely agree with you. The only way you can get hurt in the pool is if you get too close to the edge and have some
Yep.
issues. So if you have somebody with balance issues, I'm smart enough to keep them out in the middle of the pool.
Yeah.
Also, I rarely use a gait belt, but I had one guy who was what they call a Hoyer lift. I mean, he doesn't stand, it's hard enough just to get him in and out of the pool. And I had him on a gait belt sometimes, just
Yeah.
because I'm like safety's, the most important thing. I absolutely agree with you about the pool. Fear is a very interesting thing. I don't know if I'm right or not. Kind of been trying to explore it with some of our neuroscientists that we're talking to lately. But I have this theory because I see it. I see the results in performance. Seems like fear takes up a certain part of your brain, and the more you allow, the more afraid you are, the more it takes up, and the less likely you are to be able to do that task better. So I always work with people trying to alleviate fear so that they have more brain to put to the task. For example, the first time I tried to walk somebody with a gait belt without their cane, they showed up with their cane and they were carrying their cane. And I said, "What's up with the cane?" He said, "Oh, I'm carrying it for counterbalance." I said, "Okay, it's actually unbalancing you, but it's counterbalancing your brain because you want it there and you want to be able to put it down. And therefore, because of the fear factor, I'll never take it away from you." And he walked with it for about 6 weeks, and then one day he said, "I'm ready to put the cane down. Let's try it without it." And I,
Ralph, I gotta tell you this story. This
okay,
reverts back to my kids. My son Owen, when he was first starting to walk, he walked around with those poppers on wheels. You know, you push them. They have two wheels. They have a bubble with, so you
yeah,
push it and it goes pop 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 pop. Anyways, he would not walk without that. We took it away. He sat down, like he was afraid. So we had him stand one time and he just needed something in his hands. So we gave him a raisin in each hand. We called them the magic raisins. So he held the raisins and then started walking because he had something in his hand, and it eliminated his fear because it gave him that sense of security. Did it actually physically do anything for him? No. Did it mentally do something for him? Yes, they were the magic raisins. You
okay, well,
know?
here's the other thing. Almost everybody out there that can walk will walk better if they put their finger on their friend's shoulder. I mean,
Yeah.
I've had people do it with me that when I'm transitioning, away from cane or, and away from the gate belt even, I'll walk next to them. And it's just amazing. You put a finger on somebody else. I think I sent you the video when we were talking about play in another group. I sent you the video we did of stroke camp. And we had a guy walking on two by fours, kind of a challenging terrain, and he had trouble with it. And my friend, the occupational therapist, who also has kids, who is the one who got me into the whole thinking about play, he walks beside him and lets him walk 3 times with his finger, and it ends up patterning him. And Brett ends up walking the fourth time better. So it's kind of like the bilateral, the fear, all of that coming together. And these are the things that we're trying to explore here in this group because a more focused approach to things, which often can include science or it could include ways of stretching or working with the way spasticity works, makes a lot more sense than going to the gym and trying to throw some, iron around. I mean, not that
Another
there's anything wrong with weight training, but
Yeah, another thing to think about with regard to fear, though, is it taps into the sympathetic portion of the autonomic nervous system. It
ah,
puts you on fight or flight. It puts you on muscle guarding. So if you have spasticity and you are fearful, that spasticity will take control because it will foster reflex activity.
now I want to know what how the amygdala plays into all this because that's our flight and flight mechanism. I have a very interesting video that I'll send you. My same friend, the occupational therapist, uses fight or flight with some hand motion. He basically scares people into thinking that he's going to rip their arm off, and it actually works. He's like you. He explains it. He says, "This is John's theory. Like, you and I've talked, like, you noodle around. You said earlier your stuff hadn't been peer reviewed, but you have Mitch's theory based on your observations. We could do another hour on the whole thing about observation, noodling around with yourself, trying stuff, body awareness, paying attention to what you're doing, because it's not just about, okay, I'm going to do hook this TheraBand up and I'm going to mindlessly do this. Just a simple TheraBand move. The down, this, but and so do a lot of our folks. But you can jerk something up and you can jerk it back down. But the point of I've always found that control is the issue. When you go down, you're doing more work, especially if it's controlled,
Yeah,
because
eccentric. Yeah.
right, and well, because you're establishing proper tone. One of the things that
Mhm.
stroke survivors talk about is tone. They talk about excessive tone. Your body has a natural relaxed tone where the anti-gravity muscles are working against the gravity muscles, if there are such a thing. In other words, if you hold your arm out, you've got, you have two different muscle groups, in
Yeah.
play in a natural tone, and the stroke messes with that tone. So most people just apply tone. Well, they use tone and spasticity interchangeably, and I've been trying to study this for a couple of years. I think I got a better understanding than most people, and you helped clarify it even further today. But it's kind of a confusing situation. I want everybody out there in YouTube land to know that your body has a natural tone, and that's kind of what you're trying to get back to. Maybe that's that.
Well, I can tell you what the natural tone is. The natural tone that you're speaking of is the natural ability to grade between activation and inhibition of opposing muscle groups throughout your body. So that's what natural tone is. Hypertonicity is when reflex takes over, when that reverberating signal between your spastic muscles and your spine just it doesn't let go because your brain is not connected to it to foster that natural tone or that natural gradation between activation and inhibition.
Well, and unfortunately, a lot of people are, based on what you're talking about in your demonstration of spasticity, a lot of people are doing range of motion exercises, but they're not getting, and they may be getting some benefit out of them, but they're not getting the maximum benefit out of them. That's why I was saying earlier about, science and knowledge allow us to
Yeah.
take a more focused approach, and focused approaches result in uh, better outcomes.
Also, it helps if you do those exercises as a breakdown of a meaningful functional task. Elbow flexion extension. You could think when you're doing that, you could think about bringing a cup to your mouth to making it meaningful. Instead of just doing it because I need to be able to bend my elbow. Well, that's not very meaningful. But if you tie function and actually think about function while you do those resisted exercises, you're mapping it better.
Right, and
And
that's
then
why. Go ahead. I'm sorry.
and then actually try to do the some modified version of the functional task afterwards, whether it be active assistive with both hands, or if you can do it with just your affected extremity, then do it.
Right.
That's going through all the phases of increase range of motion, explore range of motion, apply range of motion.
We also believe as a group that therapy is all around us. And I would get out the glasses when I couldn't do something like pick up a glass with my affected hand and put it to my lips. Yeah, and I did it with both hands. Actually, you can take, I noodle around a lot like you. So I look at patterning. Um, and I actually took a spatula one day and I was trying to move it like that at the sink to wash it or to scoop something out. And I didn't do very good. So I took this hand and I moved it 3 or 4 times.
Yeah.
And then bingo, I could do it. Um, so I did that a lot with, picking up glasses. When I didn't like the way I set down a glass, I'd pick it back up and set it down like in daily life. So I didn't like it, I'd do 4 or 5 till I got a good one and try and leave my brain with the good one. And so we all believe in washing dishes. I try and preach to people, well, but I can't. My hand doesn't work. Well, okay, maybe washing dishes with the fine china is out of the question. When I started with the glasses, I got out the plastic picnic glasses. And sorry, I didn't turn my phone off. Um, so therapy's all around you. Maybe you don't want to start with the dishes, but if you can, start pinching it all, you can do like piggy bank exercises with coins and wax on, wax off. Everybody ought to be washing their cars and cleaning their cleaning their cabinets with their affected hand, in my opinion.
So Ralph, I can take another question, or we can stop it here. Whenever we choose to end it, I did want to try to say that one paragraph that I read to
Oh
you
yeah,
over the
no,
phone.
absolutely. If you're ready to do that, that's fine with me. We covered a lot. I
Okay.
mean, like I said, we could probably have you back 10 times before we, no, not even then, because you're constantly exploring, and that's the thing I like, because I did that in my recovery, and I'm trying to encourage other people to learn body awareness, break things down. I actually had one guy where I said, don't intentional walk for about a month. We'll do all the parts. And I had him do all the pieces of walking and then walk again. He said his walking improved without intentional walking. He just walked around to go to the bathroom and get meals and such. He didn't go outside and walk for a period of time. So I'm a big believer in breaking things down, noodling around, trying things, paying attention to your recovery and seeing if you can maximize it. So go ahead and do your ending
That
paragraph.
paragraph.
And
Yeah. Okay. So this is I have like a 20-page document of post-stroke rehab. So this is at the very end. I figured this out from a fellow stroke survivor I was helping out. So I told her, remember to orient whatever you work on from now into the future on functional goals that you want to accomplish. All of the interventions and tools that you acquire throughout your rehabilitation status post-stroke are too much if you try to use/practice everything. Think of the array of tools that and techniques that you have gathered and will continue to acquire as multiple colors on a palette. It is up to you to decide how you want to use them to paint your picture of functional mobility. So I hope that resonates with all of you out there. Um,
it
let's
does with
see.
me for sure.
Um,
It's well stated and beautiful.
so so I mean, as we said, we could go on, but I think that's a good conclusion to our discussion right now.
Well,
I apologize if you guys had questions and we weren't able to answer them. I'll leave it up to Ralph if he wants to, gather questions in the future for some other future Q&A or something like that. But
well, one
sometimes
thing,
questions come as you process the information.
one of the things that we'd like to do, and we've kind of gone from like a group chat to a more focused and scientific approach with knowledgeable guests like you. And one of the things that, and that's been a challenging transition because it involves a lot of work. I'm not complaining about that, but one thing that I'd like to get to is where we publicize these things more in advance. We could like maybe make a topic. We could throw out some potential questions that we're going to answer. We could get people thinking about it more than like a day or so before the meeting or during the meeting when they, join, because I think that would bring more robust conversation. So we can talk about that, and I really appreciate you taking your time today and sharing your knowledge with us. I'm a big believer that the clinicians that have suffered stroke have a perspective on it that no one else can. I mean, you work with other physical therapists. They can be great physical therapists. I've gone to neurodevelopment trained physical therapists, and they at least start with the brain instead of the body. Um, but there's something unique about someone who's experienced both sides of it. And I think that your patients are lucky to have you. Um, and unfortunately, you had to have a stroke to and go through the recovery process to gain the knowledge that you have. But I think that you and other stroke survivors who are also clinicians have a lot to provide to us stroke survivors because you understand what we're going through in a way that somebody who hasn't had a stroke hasn't. So um, I appreciate it. I know everybody out there who listened today and everybody who's going to watch it on YouTube did, and maybe you and I can continue to have some further conversations and bring you back for some other discussions. I'd love that if you're willing. And
Sure.
I won't put you on the spot right now. Well, I guess I did. But, you know, there's a lot more to explore here. And uh, we appreciate you coming today and sharing everything that you possibly could in an hour. Uh,
All
so,
right. Well, thank you all, and I wish you all the best in your recovery. And just keep on working, keep on exploring, and don't forget to have fun. All right.